Thank you all for joining to today's webinar, Realising Community Engagement in Global Health. Communities play a vital role in supporting health and well-being, and they need to be at the centre of efforts to achieve and improve quality, accessibility and equity of health services, and they need to be at the centre of efforts in achieving universal health coverage. Thank you for taking the time to be here today to take stock and explore progress, opportunities, challenges in achieving this important goal of realising community engagement in global health. My name's Anna Sunda and I'm the Programmes Manager at Women and Children First. And we are hosting this webinar today together with University College London. We feel very fortunate to be, we feel very fortunate to be coordinating this event today, but we would really like to acknowledge the critical critical consortium of partners who were really important in developing collectively the Participatory Learning and Action approach, also known as the PLA approach or the Women's Group approach, and who have since then adapted, implemented, evaluated and scaled this approach in their local settings. And so I would like to welcome you all. It's great to reconnect with you all. Mira, Ekjut, PCP, Sneha, Maimwana and Maikanda. Welcome everyone. I would also, it's also a very exciting opportunity to connect with new partners who've been working with PLA as well as a really exciting opportunity to connect with key stakeholders who are interested in the agenda of community engagement. So welcome all. I really do hope you're safe and well in these concerning times. Throughout the webinar, the webinar is divided into two sessions, panel sessions. The first panel will look at the evidence around community engagement and particularly the PLA approach. The second panel will then talk about this community engagement agenda, the need for it, how to take it forward, how to scale it. We are really joined by a great set of panelists and moderators. Each of them will be introduced individually during the panels, but I would like to extend a huge thank you to you all for joining us here today. We will be running a live Q&A session at the end of each panel. And you can submit your questions by going to the Q&A box at the bottom of your screen. We would really appreciate to hear from you, so do please pose your questions throughout the panel and they can then be answered in the live Q&A. You can upvote a question by clicking on the thumbs up icon. And if you do run into any technical issues while throughout the webinar, then pose your issue in the Q&A box as well, and we will hopefully address that as quick as we can. But don't worry as well, we are recording this webinar and it will be shared with you after the event in case you do miss anything. It's now my pleasure to hand over to our first moderator for panel one, and that's Professor Audrey Prost. She's Professor in Global Health and she's the Director of the Centre for the Health of Women, Children, Adolescents at the Institute of Global Health at UCL. Thank you.
Thank you very much, Annie. Hello, everybody, and a warm welcome to this special webinar on community engagement to improve global and public health. In this first panel, we're going to talk about evidence, including new and emerging evidence on the role of community engagement approaches, especially participatory learning and action, but also moving beyond that to other community mobilization approaches. We are joined by five very exciting speakers who will share their experience as well as new evidence and key learnings. And our first speaker is Suchitra Rath, who is the Process Evaluation Manager and Program Lead at EGJUT. EGJUT are a civil society organization based in India, in Jharkhand, and they have recently completed a very large scale-up of participatory learning and action to improve maternal and newborn health across the state of Jharkhand in eastern India. So I'd like to start this discussion by asking you, Suchitra, what you and EGJUT have learned from your experiences in scaling up participatory learning and action for maternal and newborn health. What worked for you and what was challenging?
Um, Thank you, Professor Audrey. Hello, everyone. And first of all, I would like to thank the organizers for this opportunity and my organization for nominating my name to represent the FLAG team and the FLAG team for all their inputs. FLAG, or Facilitated Learning and Action Groups, is an initiative by the National Health Mission Jharkhand to roll out PLA meetings throughout the state for reducing maternal and newborn deaths. For this program, the collaboration was between National Health Mission Jharkhand, and which is the flagship program under the Ministry of Health in India, National Health Systems Resource Center, and EGJUT. And we were supported by Children's Investment Fund Foundation for the scale up. University College London did the evaluation. So all four of these organizations needed to be convinced that this is likely to be effective, and they needed to be on the same page on minimum requirements that needs to be met at the field level for the intervention to be effective. um, I'd like to mention that the efficacy trial, which was completed in 2010 to scale up in 2015, the number of intermediate steps that were taken actually helped. So it was not jumping from efficacy trial to statewide scale up. There were a number of other steps that was followed, like scaling up in the control areas where the first trial was done. Then the experiences of moving from voluntary organization supported facilitators to engaging with government frontline workers. We had fairly a good idea about how the frontline workers could be involved and the challenges thereof. So that was also a learning for us. And again, in the statewide scale up also, it was not done just from the word go. So the program was initiated in 6 blocks from 6 districts, representing all the 5 commissionaries in Jharkhand, thereby giving it a reasonable spread. I just wanted to mention here that blocks, districts, and commissionaries are the administrative units. Mm, Even before the cascading model was done, first we tried out to see what challenges were involved if we directly train the ASHA cadres. So ASHAs are the accredited social health activists. Like the logistical issues, time taken for training them, and the difficulties that needs to be overcome, and also how it can be done by not overburdening the frontline workers. The meta study of 2013 had also spelled out some of the criteria that needs to be met for this intervention to be effective, like what percentage of indigenous people should attend these meetings, or what should be the coverage of these meetings. I'd like to mention all these things that the prior evidence of working also helps when you scale up at such a large scale. And similarly, the surveillance system, which is a key informant driven evaluation for measuring newborn mortality in the field, has also been tried in the past. So there was an understanding of how it is likely to give robust data for evaluation. So logically, we went through stepwise. If I summarize it, it is like doing the right things right first time and every time. So the cost of rework can be avoided. Again, these meetings had many stories, and from listening to the stories of pathways to change, the frontline workers learned a lot of things that are context specific. and not that are desirable or that comes from expert or from the top. So the learnings help the Asha build the rapport with the community, and she is also aware about the pathways of change, and it in turn helped in making her work improved, and she was more likely to visit homes. Even the Ashas, they are trained on the basics of newborn care and maternal and child health. Going through this training program, they found that it value added to their learning, and the PLA meetings also value added to their existing work. And then for doing the scale up, we also needed to do a few things. In the process, some of the systemic problems also got resolved, like uneven distribution of workload that got rationalized. And for the MIS also, we needed to logically rearrange the clusters based on the ASHA and ASHA facilitators' accessibility. So this process ensured ASHA facilitators to commute to all villages and hamlets to deliver her role or her assigned task. So reclusterization not only aided implementation of odd and even method of on-the-job training. Actually, I would, due to lack of time, I would not mention much about it, and it's in the presentation how what it is about. So I would like all the, when it is already shared in the presentation. So this odd and even strategy also ensured that all villages and hamlets were visited. So we used, like it is said that we use the carpenter's rule of measuring twice and cut once. So to reduce the errors. So before the scaling up, whole lot of preparatory work that needs to be done. We knew fairly how it is going to pan out when it is scaled up. So in conclusion, the learnings were all the stakeholders needed to be on the same page, and we have some optimum understanding on the success of a program and the rationalization of workload if it can be done beforehand. And the work is not just for achieving certain goals, but also if the work is empowering the ashas or the frontline cadres, then certainly it will help in their job enrichment. Regarding, like you mentioned about the challenges, though I can't remember more about the challenges. However, the challenges we faced were were addressed. Like I would like to, I'd like to give a few examples.
I'm afraid we'll have to take this to the discussion to allow other speakers to have sufficient time. That's really fascinating. Thank you so much. And it's also the largest evaluation of participatory learning and action at scale with government incentivized workers. So all of the things that you mentioned on the job training, the involvement of multiple stakeholders at different levels of the health system, that's really useful for anybody who wants to scale up this intervention. So thank you so much. We'll return to you in the discussion. I want to turn to Jo Drozdevska, who's the head of programs at Women and Children First, and to ask Jo about WCF's experience of working with participatory learning and action beyond rural settings. So the WHO recommends participatory learning and action to improve maternal and newborn health in rural high mortality areas, but WCF has been taking that further. What have you done, Jo, and what have you found?
Thank you, Audrey. So thanks to this ever-growing evidence base on PLA, we were able to identify what are the criteria which are necessary for the approach to work to change communities' knowledge, attitudes, and practice for improved health and ultimately reduce mortality. So armed with this knowledge, which Suchitra also mentioned in her presentation, WCF and other PLA partners started implementing the approach in different settings than the traditional rural setting. These programs include partner Health Prom, working in post-conflict and still insecure districts of Afghanistan, Health Poverty Action with WCF, working in internally displaced people's camps in Myanmar, and Wellbody, together with WCF, working in peri-urban areas of Freetown. And just a quick thank you to the colleagues from these organizations from preparing their presentations on those projects, which you can find on the event website. So even though this was all new territory for PLA, as Audrey mentioned, the recommendation based on all the evidence was predominantly for rural settings. we were very encouraged to learn that PLA has worked very well in all of them. Groups came together to solve their maternal and newborn health problems, improving care at home and increasing seeking of care at the health facilities. And even, as was the case in Sierra Leone, starting a new local clinic, all through mobilization of communities. So before looking at the characteristics that made this possible, I'd like to briefly look at the unique challenges these settings have posed. In Afghanistan, they included certain harmful beliefs and lack of security. In Freetown, it was working in a very busy peri-urban area. In IDP camps of Myanmar, it was making your group stand out from the various different activities organized by humanitarian NGOs. We all know the cornerstone of PLA groups is that communities are in charge. And who better will know how to overcome those challenges than the communities themselves? And it worked in these settings as well. Key roles in the process were played by PLA facilitators and group committees, which are composed of active and respected community members who together know how to mobilize their communities. They know what works and what doesn't. It was also really important to have a system of mutual learning between the different group facilitators and between the facilitators and project team to joint any issues coming up as they arise. So now, what were the key common criteria that enabled PLA to be successful in these diverse settings? In addition, of course, to the commitment of the communities themselves, they include, first of all, widespread concern about the issue being tackled. In this case, it was maternal and newborn health. PLA works best when there is wider community involvement and interest in the issues to be tackled. Not everyone has to be directly affected, but will likely know somebody who has been affected or might be affected in the future. Secondly, it's social cohesion, a level of pre-existing trust and bond between the community members. In Freetown, for example, we had to be cautious as previously one of the PLA trials delivered in a large setting of Mumbai succeeded in some behavior change, but has not resulted in significant reduction of mortality. Importantly, there were a few key differences between these two peri-urban and urban settings. In Mumbai, the communities were transient and mixing people from across the country. People migrating to the urban areas of Freetown, however, often settle neighborhoods with people from areas with shared cultural and religious norms and values, which increase their social cohesion if they only just recently entered the new community. In addition, in Freetown, the social cohesion was heightened by the then recent Ebola outbreak, which necessitated communities across the country to take action to limit the spread of the disease. So the timing to continue this community mobilization with PLA worked very well. And a final criteria that needs to be met that I want to mention here is maybe simple, but not always possible. It's having the physical space and time to meet. All of the communities in my examples were busy making their living. So it was really important that they not only saw the value of the groups, but that they could find the time and space to comfortably come together and discuss their issues. We know from the Mumbai trial, that aspect was one of the concerns holding the groups back. Whenever we discuss potential new projects and new settings where PLA might work, we carefully discuss these criteria by the PLA team and with the stakeholders who have a nuanced understanding of the communities to jointly assess if PLA is the best and appropriate method to improve health of these communities. Thank you.
Thanks so much, Jo. Brilliant. So having concerned community members in group, social cohesion, having enough physical space and time, these all seem to make a big difference in your projects beyond rural areas. That's really useful. I want to turn to Dr. Nerine Darwala, who's the director of the Program on Prevention of Violence Against Women and Children, as well as Project Tara at Sneha, the Society for Nutrition, Education and Health Action in Mumbai. And Nareen, your experience is really critical because many organizations want to work with community groups to prevent violence against women, and they don't necessarily know where to start. You've been leading a very large evaluation of community mobilization to prevent violence in Mumbai. Can you tell us a little bit about what you've learned from it?
Thank you. Thank you, Audrey. Thank you, Women First and UCL, for inviting me. So I think, first of all, the first thing I would like to say is that urban slums are very, very complex. And the complexities that communities live in and NGOs like us have to work, it makes it harder really to do community mobilization. And I can say that from my own experience. One is, of course, working in urban slums, and second is working on an issue like violence against women and girls. So both makes it very complicated. And when we really started work, it was hard. It was hard to mobilize communities because their needs were survival in a very complex setting. Survival was so important for them, but violence was always on the back burner. And we see that again in COVID times also, where even after having such a huge community outreach, COVID times have made it so difficult because all women say we have no food in the house. So I think when we talk about community mobilization in urban slums, a new finding that I can really talk about from our program, and we have been running the program for many years, on the basis of which we evolved the theory of pain on community mobilization to prevent violence. And we have embarked on a trial. We have almost finished 2.5 years now in the trial. And what we learned, and it's very protocolized, and we are working in 48 clusters in Mumbai, very protocolized modules that we are now running with women's groups and men's groups. And what we really learned from doing this is, one, in community settings, ELA which we use definitely really helps. But for us, ELA is making inroads into the community, knowing a new community and working with it. What is really important is ELA helps in building that credibility. That we are here with you, we are here to help you, and we are here to prioritize whatever problems you have. But beyond that, if we want to work on violence, and I'm especially talking about violence, I think ELA has a limited role to play. And then what really, really is important is, how do you really mobilize communities to make them understand that this is not an NGO's issue. We are outsiders, and this is something you have to deal with. This is your issue, and you will have to come up with strategies to deal with it. And so that is very important, and that I think in any setting, it is important to understand that support from an NGO besides doing ELA is very, very important. And the second thing we learned about urban spaces, and I think in urban areas, of course, space is always a problem. But for us, we have never had that problem with space. I think it is how a relationship is built. It is how credibility is built. And most of our women's group meetings, they happen in houses, in small little houses where women openly ask us and give us space to carry out meetings. So I think that is a big learning for Sneha, that it isn't about space, but it is about the methodology and how you really approach communities is very, very important. And the second thing we learned is it's a theory-driven trial, and the theory of pain was very participatory. We involved community members to understand what pain means to them. And I think that when you truly make them participate in your program, that is where your parameters of success will change. Of course, we don't know what results the trial will bring, but at least we can hope that it might just, you know, help in preventing violence. So, and no matter how structured and protocolized you are, community demands are so many. So making changes in your PLA, making changes in your program is always necessary. Yeah, thanks a lot.
Thanks so much, Nadine. Brilliant. So thinking about the strengths, but also the limitations of PLA and what else organizations have to do and to provide, especially for complex issues like violence and complex settings like informal settlements, participatory theories of change, and the idea that it's not just the space that matters, it's the methods. That's all really useful. Professor Kishwar Azad is with us today as well. Professor Azad is the director for the Diabetic Association of Bangladesh Perinatal Care Project, which has actually moved far beyond the perinatal period. And Professor Azad and her team have led a trial of participatory learning and action to prevent diabetes in rural Bangladesh. So we want to ask her about this. What did BADAS and PCP learn from adapting PLA for diabetes prevention in Bangladesh? What did you find useful? I'm afraid you're still muted.
No. Right. Thanks, Audrey, for the very interesting question. I think I'll go back a little bit to the MNCH issue when we addressed it by doing community mobilization with PLA. As you know, that was a limited subject we had to discuss. It was mainly women's health and early neonatal mortality. So that was directed towards a certain population, that is women of reproductive age, and not much emphasis was given really on involving men, although they were encouraged to join. But the difference between the MNCH intervention and the diabetes intervention is that we were addressing a population of adults, both men and women, age 30 and above. And so, I mean, there is the big difference. You are actively involving men here, right? And that posed its own problem because, you know, the timing for meetings was different for men as different from for men from women, because we could only involve men in the evenings when they were free from their work, whereas women were very reluctant to come to meetings in the evening because of security issues. As far as our MNCH intervention was concerned, it affects only a certain period of time, just the time of pregnancy and before and after, so not very long, whereas diabetes affects the whole life. And in addressing above, we were also bringing in the health of younger people, because if they are fat and if they eat unhealthy food, then they are more likely to develop diabetes in the future. So it was not just a certain age group. Also, diabetes is a chronic condition. It affects, you know, the whole life actually. After you've developed diabetes, it doesn't really go away. I mean, even if you control it, there's always even if you control it to the point that it's not, you're not diabetic anymore, you don't have diabetic sugar levels, but still you are at risk for it to recur. So that was mainly, that really was the main adaptation, that you have to address a much longer period of life, and also that we have to include men. And because in our country, diabetes has been on the front page for a very long time, through mainly the efforts of Diabetic Association of Bangladesh. So people know about diabetes. There are affiliated associations in all the districts of Bangladesh. So people are aware. So they were more or less very interested in participating in this intervention. So we didn't have problems getting people to participate. It was how to do it, how to adapt. And now we know that PLA is, I think, a most useful kind of method, because it can be, I mean, anything can be adapted. I mean, we can use it for education, we can use it for, preventing abuse, etc. So we addressed, I mean, obviously the content of the manual changed. So we were mainly addressing the risk factors of diabetes, like the lifestyle changes, like, you have to exercise, you must maintain a healthy lifestyle, a healthy diet, less oil, less salt, etc., less sugar. And so even, for example, exercise was quite a difficult thing to bring to the attention of women, because they didn't like walking alone or even in groups. When men used to point out and say, oh, why are you walking? Have you got diabetes? So then they formed teams to go out walking early in the morning before they get involved in their activities. And that worked really well. So you can see women going for walks, and they also swim, because in the rural areas, women use ponds for bathing, so they can swim also. And then we encouraged them to have blood glucose sticks. So that was also, I mean, they were quite eager. Now the challenges we find is actually setting up groups, is where to hold the meeting. But I think that is easily overcome, because the village members come forward with, with space in their house, like a big, there is usually a space in the well-to-do houses. So they hold their meetings there. Then you have to get the timing from men. But my main challenge is scaling up. So I need to find out from Suchitra how they did it, because we don't have the equivalent of ASHA. But I'm sure we can find some way. I was thinking, right, putting the ball in the community's court and asking them if they wanted to scale it up, so that the intervention, benefited other people. And how would they do it then?
Fantastic, Kishra. I might have to stop you here, but you've given us a perfect springboard back to Suchitra's Scaling Up Challenge, and also to Dr. Ed Fottrell, who's our final speaker for today, and is an Associate Professor of Epidemiology and Global Health at UCL. And we've asked Ed, using his bird's eye view and knowledge of community engagement and health, to think about research priorities for the future. So Ed, you've listened to all of our speakers and you have an extensive knowledge of this field. What do you think are the 3 top research priorities?
Thank you very much, Audrey, and thanks Annie and WCF for inviting me to be part of this discussion. It really is lovely to see so many friends on the panel, and a privilege to be in the presence of the world leaders really in PLA and community mobilization. So as Audrey said, I've been asked to reflect on kind of key future research perspectives for PLA and community mobilization. And of course, predicting the future is very difficult. So I'll just kind of reflect on some that I think are key priorities going forward. But of course, any predictions that I have going forward are based on my own experiences. And my first exposure to this type of work was as a researcher working with Professor Kishu and colleagues on community mobilization in Bangladesh. And to this day, the preliminary analysis that I did in my hotel room in Dhaka some years ago, looking at the quantifiable impacts of PLA on newborn survival, remains the most thrilling professional experience of my career so far. And so no doubt that shapes what I see as the key ambitions for PLA research going forward. And to me, the key research priorities fall into interrelated concepts or categories, and each of these are dynamic and complex. And these are contexts, digital, and for want of a better term, health outcomes. And so we've heard a bit about contexts already and the different places where PLA has been applied. And we've heard from Nirene of the work in Mumbai, and Joanna talked about different contexts where Women and Children First are working. And the work that Nirene described follows on from earlier work by the team in Sneha. And that work identified really significant barriers to PLA implementation on neonatal outcomes in the very complex urban context of Mumbai. And this was sometimes described as a successful failure because it shed so much light on the mechanisms through which this type of intervention might work and the importance of context. And now more than half of the world's population live in urban areas, increasingly in highly dense cities. But these contexts are relatively new in human history, and they've transformed how we live and work and how we build networks and how we build collective action. So for me, a key future research priority is to understand how community mobilization and PLA can be adapted and implemented to improve health in urban contexts. And of course, context encapsulates not just the physical environment, but history and politics and economics and the health systems and all the other things. And these are likely important determinants of how group interventions based on social interaction and collective action can work, as well as their sustainability and their scalability. So future research must understand context better, and this inevitably will demand mixed methods research and broad interdisciplinary collaborations. And indeed, I'm really encouraged to see that this is already happening, including in new settings in Asia and Africa and in the UK. And often I'm particularly pleased to see that this includes community participation in the research process in interpreting research findings that we get from this type of work. And of course, epidemiological context is also really critical. And sorry to mention it, but COVID has undoubtedly affected what PLA community mobilization looks like and how it might be implemented. And so within a context of social distancing and lockdowns and suspicion of outsiders, it's suddenly unfashionable and potentially risky to call groups together. And this is a challenge that we're facing in our current work in Bangladesh. And we're going to have to think about how we can adapt groups and the composition of groups and how they're implemented to deal with this challenge, which will remain with us for some time. And just as we're holding this meeting remotely via the internet, future research, I think, is also going to have to find alternative ways of facilitating group interaction for community mobilization. And in this regard, I come to my second aspect, which is digitalization. So virtual groups are a possibility in many places, and at least in the future. And I worry a little bit about what this means in terms of social interaction, personal interaction. But I think there is a role for digital, and it is likely to become more important and increasingly possible to do this in the future. And I think it holds great promise. And finally, to talk a little bit about health outcomes. And as COVID has shown us, changing health priorities and emerging challenges will drive research and innovation. And this is also true for community mobilization and PLA. And you've heard from Professor Kishu about our work in Bangladesh on diabetes, which responded to what could be described as an NCD emergency in that context. And other health outcomes for which we and others are exploring PLA as a solution now and into the future include childhood injuries and cardiovascular disease and mental health and childhood obesity. But actually now more than ever before, I think we're aware that the traditional kind of biomedical conceptualizations and categorizations of health and single disease outcomes is flawed. And so I'm greatly encouraged by the growing attention to syndemics, I think, which better capture the lived experiences of health and illness and create new opportunities to reconceptualize health and focus on the broad conditions that produce health. And to me, this fits perfectly with the ways in which we hypothesize that PLA and other approaches to community mobilization works and the unexpected benefits that they produce, which are often not just about the disease outcome, but also about some phenomena that we find difficult to measure, such as social support, community cohesiveness, well-being, stigma, stress, and collective action. So in this sense, my hope for research is that it will focus more on understanding the complex social processes through which health is achieved and how PLA contributes to this. So to summarize, I think with a future of research focused on understanding contexts, especially urban, digitalization and holistic conceptualizations of health, I think I'm striving and looking forward to reliving the thrill of observing the positive impacts that PLA can have. Thank you, Yods.
Fantastic. Thank you so much, Ed. So context, especially urban context, digitalization, and thinking about health more holistically, including thinking about syndemics. I'd like to start by asking our panel members what they think of Ed's prioritization. Do they agree with this priority setting? Are there other research priorities that matter to you? Let's see who would like to respond to this.
Shall I go first?
Please, Suchitra.
Yeah, we agree with you, Ed, and actually, the points you have mentioned are really the future areas that PLA needs to explore. And from the COVID thing, I would like to mention about about a research which remained unfinished. Audrey, I want 1 minute more for this. Sorry. Because I want to mention about our work with adolescents and young people, and through 4 mini cycles, we were trying to see if there were some improvements in reducing dropouts and behaviors. But during the final survey and due to COVID, we had to stop the data collection. Based on the time and the condition, it was a right thing to do. But this question will always remain unanswered if someone doesn't take it up to see what if we would have completed the data collection, then what would be the result. So I would like to start with this first. So basically trying to mention that if someone could take this up and take it to a logical end. Secondly, in the face of the secular changes, these interventions seem to be effective. Like I was mentioning about the efficacy trial, we were and even the WHO recommendation that PLA works in high mortality settings. But in the context of these secular changes, even it is working in the lower, even when it is much lower than newborn mortality. So we would like to understand what are the pathways to improvement now compared to in the past. So that could be an area of inquiry. And the third is we are working with persons with severe psychosocial disabilities. So many user groups of various kind. We feel probably it would be the right thing if one of them, like if we want nothing about us to be our motto, then how can these facilitation skills be transferred to the user groups will be something that we would like to learn. And even other community mobilization methods like the social audit shows some immediate results, like grievances getting addressed. It would be interesting to see how, if the same principles of intention to treat is applied there, so does it apply, does it benefit the large community, large scale in the community, or it only benefits to those cases highlighted in the social audit?
Thanks, Suchitra, for making a pitch for young people and for looking at mental health also. There's so many issues that one could look at. It poses problems for priority settings, doesn't it?
Yes.
Dr. Nareen, I see you nodding. Would you like to add something?
Yeah, so I think what Ed said, I agree with the priorities, but I do have a reservation with digitization, and the reservation is, I think the whole principle of community mobilization is solidarity and women coming together and wanting to be together. And our experience was in the first 2 months when COVID was really very, very rampant, it was okay. But as soon as things became a bit better, we started online activities. And despite telling women not to meet, they wanted to come together and meet and share a phone. So I think in terms of digitization, of course, this is the new normal and the new way to look at intervention. But if we truly talk about community mobilization, then I think we have to look also at other aspects of solidarity, gregariousness, and how women and men want to be together in communities. So I think we might face a challenge there. For example, all our crisis work, the counseling work has been happening on the helpline for many months. And now when it has opened up, women are still coming to us and wanting to talk in person. So I think we really need to figure out how we will handle this whole digitization.
Thank you very much, Dr. Nareen. A word to the wise about the perils of digitization.
So
I'd like to address one of Ed's I don't know, questions or whatever. I mean, we need to do the PLA intervention in the urban setting to find out if it can be replicated, because as you said, that the urban population is getting bigger and the rural population is shrinking. So we have to think about urban intervention, include PLA in that, because the problem with urban slums is that there's not enough space. One, and the other thing is people go out to work at different times. So can we get them together? Can we find a space to do this? And besides, in urban areas, like for diabetes, it would be very important, because urbanization leads to diabetes mellitus. So that's my, that's my response to Ed's. What was it? He raised a question about urban, yeah, replicate it in the urban setting.
Yes, thank you very much, Kishra. So there's an emerging consensus that there needs to be more work on community mobilization in urban areas, be it for violence or for non-communicable diseases. Really interesting. Joe, I think you wanted to come in.
Yes, just linked to what the other panelists have been raising, cautious of all these issues that are emerging at WCF, we also started a pilot test in Ethiopia of a slightly adapted PLA approach, which we refer to as a curriculum approach. And for those in the audience who are not very familiar, traditionally, each of the steps of the PLA cycle would have a dedicated meeting that happens once every few weeks. Those are the problem identification, the problem prioritization, problem identification, a solution identification, a solution implementation, and ultimately evaluation. What we're trying to do in Ethiopia is to have 3 of those first steps to take place in one meeting. So the groups come together, prioritize their health problem, come together with the best solution, and start implementing that solution shortly after that meeting. So what we're trying to test here is whether groups through this setting, can they cover more health issues, because they would start implementing, they would be looking at various issues which would be underpinned by one overarching issue that they're trying to tackle. So this would speak to what Ed was saying, that actually to have a more holistic approach in terms of people's health. We think this would be feasible also because from the experience, we know that the solutions that groups develop and implement, there's a few types of those solutions. So even though the breadth of what they're discussing would be wider, it wouldn't necessarily require them to implement more solutions. And we're in Ethiopia specifically, we're looking at implementing this for family planning. So we know family planning is it can be very complex for women to find family planning that works for them. So we think this approach of discussing more health issues related to family planning will allow the groups to discuss the issue from the different angles and implement the best tailored solutions. So yes, we've only just started. Luckily now groups can meet, and we'll definitely share our findings as and when we have them.
Excellent. Look forward to hearing what you learned, Joe. We've got lots of questions coming in from participants. The first question is about, and we always get this, the difference between participatory action research and participatory learning and action. Let me put it to our panel members first, who are expert in this. Would any of you like to take this one on?
dare say, Audrey, that you might be the best placed person to answer that. I can give my brief perspective. Is I think that there's a lot of overlap. And I think that when we talk about participatory learning and action, our focus here is about intervention and improving health, and isn't specifically about research. We've often used it as a intervention that we then research and try and understand. And participation action research is a method of research, but I'm certainly no expert on PAR.
Thank you very much, Ed. Would anyone like to add something? Oh, Suchitra.
Yes. Actually, in the PLA is a 4-phase cycle, and all the meetings are linked. But in the participatory action research, they are, the planning is done. But what about the implementation? What about the evaluation and the ownership? That I think is missing in participatory action research. So it's
Thanks, Suchitra.
yeah, similar methods are being used in both the methods, but participatory learning and action is much more action oriented, and it involves community ownership. Yeah.
Thank you, Suchitra. I might post some resources and reading on this for people who are interested in the history of these methods, because they're really a broad family of methods. And this is why we also talk about participatory learning and action and other community mobilization approaches, because there's a wide range of methods that you can use within that family. Actually, Suchitra, here's a question for you. One of our participants is asking you if you have shortened the PLA cycle, made it more concise in order to scale up.
No, actually, we have, expanded the cycle issue, addressing issues beyond maternal and child health, maternal and newborn health issues.
You've actually made it longer.
Yeah. Yes.
Okay. Which comes with its own challenges, doesn't it?
Yeah.
Maybe I can speak here very briefly to that. Is that with that curriculum-based PLA, we think that also the length of the cycle can be adjusted based on the complexity of the overall issue that we're trying to tackle. Again, just a pilot test yet, but it could then enable for sort of more quick, rapid community mobilization. However, we are conscious for this to work, that social cohesion, which we discussed, already has to be in the groups, because they have to be ready from meeting 2 to take action together and trust each other to take that action. So it won't necessarily work everywhere.
Thank you very much, Jo. We've got a few minutes left, and I want to ask a question to Ed and Nyreen. It's come through our participants. They are wondering whether you plan to use digital methodologies to do community mobilization in the COVID climate. And they're considering your previous remarks, Nyreen, about the limitations of that. So are you planning to do it? And if so, how?
Yeah. So I think we are planning to do, we have moved towards digitization quite a bit, but I think at a point we will go back to the communities, because the communities do want that kind of women's group meetings that happen twice in a month. So some aspects we will continue digitally, but some aspects we won't. Since it is a trial on community mobilization, I think we will go back to the communities and try and make them do more collective action.
Promising.
Yeah.
Audrey, may I just ask one question? May I just make a comment?
Of course.
Everybody's talking about COVID. We went back, in Bangladesh, it is not as huge a problem as in India. But we went back to the community to ask if we could start our intervention again, restart our intervention, and they are quite happy for us to do so.
Yeah.
So we are going to go back. In fact, we are going back next week.
With the community support.
Dr. Kishwar, I would also like to mention here that the meetings in Madhya Pradesh and Jharkhand has already started, though keeping the protocols in mind. And the letter has been issued by National Health Mission for doing the Madhya Pradesh and Jharkhand for doing the meetings. So the Ashas are convening meetings. And it's also out of the interest of the community, where they shared that why are the Ashas not conducting meetings on such issues during this time. Yeah.
Thanks, Suchitra. Joe, Ed, did you want to add anything about using digital platforms in the time of COVID?
I can add something. So I share, I think, the concerns probably with the rest of the panel about digital. It's no replacement for real human interaction. I think we're all feeling that even during this call. But I think there's a lot of potential for it to contribute to that. We know that people love coming to groups physically and interacting, and that's one of the key reasons why groups are so successful. People enjoy coming to them. I don't think you can replace that with just digital. However, as we all become more connected electronically, there may be a role for digital in the interaction between groups, between meetings. So groups will typically meet, for example, once a month. And I think having some kind of aspect of digitalization between group meetings might be one aspect. I think the point I was making is that it's going to be a reality. We need to look at how it can be integrated. From a research perspective as well, it could be a bit of a challenge in how we stop contaminating our control areas and how we stop information and messages that we're spreading through interventions leaking into our other evaluation areas perhaps. But also just going back to the point about context, and that I think in the context where I currently work, I don't think digital is not yet the time for digital, but we've been doing some work in the UK and looking at possibilities of starting this type of intervention in the UK. And it's a very different context where, digital literacy is very high, accessibility is very high, and opportunities to gather people together in physical space is sometimes limited. So again, it's an area that needs research, I think is the main point.
Thank you very much, Ed. It feels like we've barely scratched the surface and we're already at time. I want to thank each and every one of our panelists for such fantastic contributions and responding to the participants' questions. I've come away from this feeling that we've got a strong evidence base for community mobilization to improve maternal and newborn health, certainly, including at scale now, and a strong emerging body of evidence, hopefully, coming out on the prevention of violence against women, as well as on NCDs, particularly diabetes, with the work that you've been leading, and need for lots more research on other areas, including family planning, how to work in urban context, digitization, how to understand the role of context as well. So you've given us a great agenda to move forward. So thank you very much, everyone. And congratulations on all your excellent work. I'm going to pass the baton on to Professor Anthony Costello to take us into the second panel discussion, which is about where we go from here, what next, how to scale up and how to fund it. So thank you again, everyone.
Thank you. Thank you.
Thank you, Audrey.
Okay, well, I hope you can hear me, and thank you very much, Audrey and the whole team, for setting the scene with all the evidence. My job, well, I should introduce myself. I'm Anthony Costello. I'm a professor of global health, sustainable development at UCL. I'm a pediatrician. Previously, I worked for just under 3 years at the World Health Organization. And I've had the privilege to work in partnership with many of the people on these two panels today previously. So it's great to catch up. My first observation about community engagement actually comes back to the UK, because for the past 9 months, I've been looking at the failure to a large extent of the UK government to handle the COVID pandemic. There has been almost no devolution of power to districts within England, certainly, although the 4 nations. Very little mobilization of communities until latterly, very centralized decision-making, and outsourcing of functions that normally would be done by local health services to private companies. And the results are that we actually have 800 deaths per million population, one of the highest rates of COVID death in the world. And it makes me think we're living, particularly in the West, Western Europe and the US, in a very individualized world that is looking for technological solutions. And indeed in the UK early on, back in March, I think, we mobilized 750,000 volunteers and then left them largely unused. So I think we have a tremendous amount to learn from countries where the community approach has been made. Now, we've got a great panel, and I was going to introduce all of them as we went along. I'm not sure if Nosa has joined us yet, so I'm going to start with Rajani Ved. I'm going to introduce each as I interrogate them. So I'm going to start with Rajani. Now, Rajani Ved is a highly distinguished public health physician. She's Executive Director of the National Health Systems Resource Center in New Delhi. She has a passionate interest in health systems, a focus on primary healthcare and on scaling up. And she's hugely respected around the world. But what you have to understand is that she has the biggest primary healthcare job in the world, because she's responsible for kind of stimulating the scaling up of interventions to 1.4 billion population. So Rajani, let's kick off. How do Indian experiences of scaling up community engagement compare across states? Because you're a subcontinent, and what's the state of play in India at the moment, in your view?
Okay, so thank you very much, Anthony. It's such a delight to be here, and also having heard the previous panelists, I'm sort of inspired and determined even more than ever, I think, and I'm convinced that community engagement, if you want to achieve long-term sustainable and scalable health gains, community engagement is really a very important part of it. So to your question about what's the state of play on community engagement across the country, I think India has a fairly rich history of community participation. We have local self-government, we have decentralized governance. We also have a large body of self-help groups of women, which is perhaps, across the state, every single state in India has a large program for self-help groups. Now, how well they function is another matter. It's determined by context, as many things are. So in states where local self-government is strong, where people's participation in several social sector activities has traditionally been high, like in Kerala, perhaps the southern state of Kerala, Karnataka, Maharashtra, clearly community engagement is quite strong. People's participation, people's voices, and we saw this in COVID really. And that's why Kerala actually has some really good successes to show. And early on, Kerala, and even today, I think the mortality rate in Kerala is very, very low. Their contact tracing is excellent because they've used an army of volunteers. They have ASHAs, the community health workers, that's for sure, but they also raised an army of volunteers to help with contact tracing. In other states that are not so well governed, where there's a strong tradition of power, patriarchy, then you do have efforts that are motivated by groups like Ekjut, where a sustained effort at building community capacity to undertake participatory action. And I think PLA here really stands out for me. So as you know, of course, you tested it in Jharkhand, scaled it up in Jharkhand, went to Orissa, went to Madhya Pradesh, three states which have really weak women and children's health indicators, and an increasing burden of non-communicable diseases, increasing urbanization as well. So a lot of what people said in the previous panel really resonates with me. So I think for several reasons, use of participatory learning and action, and I'm really quite excited to hear about the experiences of Bangladesh with with diabetes particularly, and urban areas, because in India, both of those are important. I think there are various forms of community engagement. We have our self-help groups, and community engagement is supposed to be inherent. We have social audits. In 2 or 3 states, it's legal. We have a social audit law there. But as somebody remarked in the previous panel, does it affect only those that have grievances? I think it raises the level awareness in the community that government is accountable to them. And so I think that's really important. But PLA, and I've seen this very closely for the last 10 years working in NHSRC. By the way, Anthony, I'm no longer director of NHSRC. I just stepped down a couple of months ago, but I continue to be associated with them. I think building solidarity for an issue and the belief that training is transformative. I think those are underlying PLA values. Inclusion, reaching the last mile, and trying to eliminate power hierarchy. So when I talked about local self-government, and that's also a form of community engagement, elite capture is definitely something that can happen there. But in PLA, we've not seen it happen. In these last 3 states where programs were scaled up, elite capture is hardly a problem, I think. And this process of shared understanding of problems and coming together with solutions is something that, and we've managed to scale it up. You heard Sujitra talk about the fact that they've made it integral to the ASHA. Now, how well that would work in urban areas, I'm a little bit, I think we need to do much more research in that. Although COVID, I think COVID here, I mean, it's got a few silver linings, and this is one of them, is that in COVID, people's trust in the public system really grew because the private sector just completely withdrew. And so now we are looking at ways of strengthening primary healthcare and public health action through community groups, not just in slums and slum-like areas, but even in affluent colonies, and trying to bring them around a platform of public health action. And that seems to be just being tried out. And this is an area that warrants research really. How do you get the non-poor in urban areas engaged in community action? Because they're not known for this. They're very highly individualistic. So I think that's an area that we need to crack. But I also think that people often, especially policymakers, tend to undervalue the costs of PLA, the planning, the structured approach, the need for very skilled facilitation, and the need for resources to train community health workers to bring groups together. And I think it's somehow assumed that PLA is just an activity that self-help groups, they can meet every week. But I think they underestimate the need for the sustained facilitation of community engagement processes. And so I'll stop there now.
Yeah, I was very interested in one thing you said there. I've been coming to India a long time, and people would say, oh, look, the public sector doesn't work well. We've got to, expand the private sector, and certainly under the current administration when they came in. But then you said in COVID, the private sector really disappeared, and it was the public sector that people turned to. And that's been a massive issue in the UK as well, where they've turned to the private sector, who have really been wanting actually in trying to deliver things that they're really not capable of doing. Could you expand a bit on how that worked? And also, did it disrupt community engagement, or did COVID, after a period, bring people back together?
So I'll start with the last one. After the period, it did bring people back together. We do have meetings, and it's really amazing to see pictures from the field where physical distance is being maintained, women are wearing masks. Very often women's group members have pitched masks from other people in the community. So they are coming back together. With regards to the public sector, I think the private sector just withdrew because of the fear of infection, because they were worried about their own employees, because they were just unable to provide them with the kinds of equipment that was needed for infection prevention. The public sector had to step in. And here I'm a bit sorry to say is because of the very limited investment in ensuring integrating public health action into primary health care, the public sector also was found deficient and took a while to actually come to grips with the situation. And it took a longer time for them to deal with the issue of non-COVID essential services. So we're going to be seeing a decline, and we have seen declines in immunization, increased reporting of deaths, poor nutrition, especially for people with chronic disease, access to dialysis, access to blood transfusions, all of that has gone down. And so the public sector didn't perform gloriously, but people had no choice, and people actually knocked on the doors of the public sector saying, you're here to give us. And so the public sector literally was forced to perform. And I think that is spurring now additional investments in the public sector. So we're seeing a lot of discussions on increasing the budget for health, which is a very good thing.
Thank you, Rajni. Just park it there. We've got other questions that I'll come back to. I'd like to move on to Charles Mansambo. Charles is a UK trained paediatrician. He's a fellow of the Royal College of Paediatrics and Child Health. He's currently the Chief of Health Services for Malawi. Previously, he was Secretary of State for Health. And before that, a consultant paediatrician, where he remains in the main Kamuzu Central Hospital, where he still practices, and where I first met him when he was hospital director there 20 years ago. So Charles, you know, you've been involved directly in two of the big trials in Africa, in Malawi. What's the current state of community engagement, pluses and minuses at scale in Malawi?
Anthony, thank you very much for that introduction. You'll be pleased to hear that Malawi government is still committed to improving the health and livelihood of Malawians through community health, and that in collaboration with partners, we actually developed the first ever national community health strategy. And community engagement is one of the 6 thematic areas in that community health strategy. So the vision of this strategy basically is to improve the livelihood of the people through ensuring that integrated community health services are of good quality, are affordable, and also culturally acceptable. Of course, scientifically appropriate and accessible to every household in the country. Of course, all that you do through community participation. And then, as I mentioned earlier, one of the key objectives of the National Community Health Strategy is to strengthen this community engagement. Of course, this we do by generating the community health support from the communities, and also building capacity of the community structures, such as the hospital management committees, the health center management committees, and we also have what are called community health action groups, and also the village health committees and village development committees. So as you can see, there are all these structures that are in place now to support this community engagements. But on top of that, there is also enhancement of social accountability by the health users at community level through issues like the scorecard. So the PLA, what started off as research, is now finally being put into practice and is high up on the political agenda. And as a ministry, we're already implementing it somehow in collaboration with partners. We've invested quite a lot in community management, and we've developed a number of community guidelines. I'll just give an example of a few. We have the Hospital Management Committee guideline, the Health Center Management Committee guidelines, the Community Action Group guidelines. So all that work is now being incorporated in what is already coming. So we encourage any partner who is coming in to make sure that they look at these already existing structures and support those. But of course, the major shortfall is the financing. I think some of these groups need, as we mentioned already, you need well-trained, skilled facilitation in some of them, in which case some of them are not adequately funded. If you're to look at all the villages in the country, there's quite a few of them that to get to each one of them needs resources. So funding is a major shortfall. As you're aware also, currently we rely on the health surveillance assistants to work in the community. Currently there are about 10,000 of them, but we set a target of about 16,500 so that we can get to as many people as possible. So as I said earlier, the key issue is on the funding, especially on these interface meetings with community members and their own meetings in the community. I'll stop there for now and take any questions you may have.
Yeah, I mean, Malawi's done, you know, since I first arrived in the very peak of the HIV epidemic, which was a disaster for the country. I mean, things have stabilized and things have improved a great deal. Having said that, and it's a question that will go to all of the panelists, one of the things for children, you know, we've heard about community groups for mother and newborn care, for child health, maybe for adolescents, maybe for domestic violence, you know, maybe for diabetes, and there are many different ways in which communities can be engaged. One of the things that really struck me, you know, in Malawi was that health is very linked to agriculture. It's very linked to the local environment, clean water, greenery, you know, all kinds of ways in which we can link the two. And you and I, you know, we wrote that proposal, and unfortunately it didn't get funded, to look at using groups as a way of linking a kind of One Health approach, which is that the, you know, most rural households, certainly they're concerned about their crops, their livestock, and their family's health, and the three are interlinked. Do you see a prospect for that? And how worried are you about the environmental and climate change impacts in Malawi, and whether or not community engagement there has an important role?
That's obviously an issue. I mean, now you can't talk, for example, now we're talking about COVID. You can't talk COVID without talking water. So you need to make water readily available. But if you destroy all the forests, if you destroy all these reservoirs, there won't be that water to keep us all clean. So as a country, we adopted what they call community-led sanitation, hygiene, and using that, we've been getting to the communities and promoting issues around health. But the environment plays a key role even in that too. So I agree with you. We have all the reason for concern, but it extends beyond health. I mean, there was a time when I was discussing with my colleague in energy that, if you provide electricity to the rural masses, you stop them cutting down the trees for firewood and charcoal, and as a result, you conserve. So it extends beyond health. I agree with you. And talk about energizing the community. If you put electricity into rural areas, the people have alternative sources of entertainment, and that will reduce them making children, or instead of you going to bed so early. So there are quite a number of factors that are interlinked. And I agree with you.
Sorry, just one follow-up to that is, you've raised the issue of family size and population growth in Africa. I was checking recently, I remember about 15 years looking up the population of Africa, and they said it was 880 million. And I'm told now it's 1.4 billion. And in another 30 years, it will be 3.6 billion or something.
Yeah, it's going up at an alarming rate. Yeah.
So the question to me is, to what extent would community engagement help with providing better access to family planning and education about family size, given that most women, or many women in Africa, do want to get access to good family planning services, and they don't always get it. Do you think there's an important role for community engagement there?
Yes, I mean, in fact, I'll just give an example of Malawi. We're already doing that. We're actually implementing sexual and reproductive health and rights, including family planning. And we've actually embraced awareness in this community involvement. At present, there's that door-to-door services of health surveillance assistance and community-based distributing agents. And this is actually enables to reach that last mile. So I agree with you, by engaging the community, you'll be able to get them access to family planning commodities more. I mean, you cannot operate just from the facilities. You need to go actively to them, not passively to you.
Okay, thank you, Charles. We'll park that for now. We're going to come back to some of these questions in a moment. I want to move on to Luwe Pearson, and another old friend. And Luwe is Associate Director and Chief of Health at UNICEF in New York. She provides strategic leadership, management, and direction to UNICEF's Global Health Program. And she's worked with UNICEF for 20 years at many levels, HQ, regional countries. She previously worked in Pakistan, China, Nepal, with UNHCR in Hong Kong, with CIET International. And currently she's interested, because she began her career as a doctor in Beijing, she trained, interested in Chinese aid programs, I see, and how they can make them more responsive to the individual needs of African nations. And this is important because China is now, I think, the biggest donor to Africa. And you had an interesting, which I want to ask you about, community-based interventions to find the best fit. Is that correct? To help millions of mothers across Africa. So Lu Wei, what's the UNICEF approach to community engagement?
I think UNICEF has always been quite strong at in country, and compared to many other UN agencies, we are somehow have wear more of the muddy boots on the ground. And more and more we, through social listening, to understand communities' views real time, mindful of there are a lot of women, the most vulnerable perhaps, do not have any digital print, right, access. So we can't just only use digital means. We need to use a balance of traditional as well as digital. In the whole community mobilization space, I learned a lot of examples myself. Give an example in Ethiopia, when I was the chief of health with UNICEF several years ago. We worked hard to bring about a policy breakthrough that was to allow community health workers to treat pneumonia with oral antibiotics around 2010. This has been a decade. At that time, we were so enthused with training them, equip them, getting the antibiotics out, getting their skills up, getting the ICCM community chart updated. Then there was an evaluation really hit me. As soon as a year into the introduction, we realized the use was very low. And I was very shocked. Why? That's when everything made available, the community wouldn't take the service. And we looked at the quality of care. We looked at the consistent presence of community health workers, the conditions, the distance. So we learned a lot of lessons that, looking back, we should have designed the services together with community orientation, including the religious leaders and other opinion leaders. UNICEF also plays an important role in girls' education. We are not a health organization like WHO. We do health, nutrition, girls' education, social protection, and many things. I feel female literacy and girls' education are absolutely important for good care seeking and make the best use of available services. And I appreciate the evidence you bring to the table today in the first session. But what I'm struggling with is how research at the level of intensity, the level of evidence can be translated into large program settings through the whatever system we have on the ground. Often the evidence and the effect gets diluted.
No, that's a very important point. I had hoped, I don't think he's with us, Nosa, is that right? No, I can't see him online. So we had hoped to have Nosa Orobaton from Bill and Melinda Gates Foundation, but I had a conversation with him last week about this, and he made exactly that point. He said, look, there is what he called the tyranny of pilots, that smaller scale things can often work where going to scale cannot. I mean, many of the studies you've heard about today are actually quite large scale, and the work in Jharkhand that ECJA have been doing has been statewide. So that's, 30+ million people. Nosa's point was that the design process takes time, that you need to build amplifying systems within the design process, so that you go with some pilot areas, but then you try and get them replicated in the same way as a business model does. And he also said I thought this was a very good phrase, he said you need repair mechanisms. So, you need to build in the kind of troubleshooting that you need to identify where things are going a little bit wrong. And, the problem is that governments are often unreliable and they let communities down. I know a lot of people in the UK that felt very let down when they, all volunteered to help with the scheme and then were completely ignored by government. So that's in Britain, I mean, this is not, I think, and America, where it's, I think, probably even worse. So this idea of ownership, of scale, of replication is, I think, extremely important. Just very quickly, before I throw it back to Rajani and Charles about that and about the environmental role of community engagement, you take a global view. I mean, looking at the situation in 2020, which countries do you think have been doing best, but where do you face the biggest challenges right now for UNICEF? Where are your hotspots and which worry you?
Are you talking about COVID-19?
No, I'm thinking more generally about for mothers and children and where community engagement might play a role in helping. Because COVID, I'm hoping that COVID is going to be kind of suppressed in the next 6 months with a vaccine. That's a bit optimistic, but we had another vaccine report this morning showing a high efficacy.
We have seen that community engagement is really important in prevention of reduction of transmission of COVID-19 and the infectious diseases. Right, we're not just facing COVID-19. We still have Ebola. We still have cholera outbreaks. I feel the emergency that communities do get mobilized for the good public health interventions, and many countries have really reduced transmission COVID-19 without a new vaccine.
Yeah,
such as in many of the East Asia countries.
Yeah, absolutely.
Yeah, and I feel we have not used enough of the good old.
Absolutely. No, I mean, you look at China. I mean, China is running at 3 deaths per million. South Korea at 8 deaths per million. Taiwan at 0.4 deaths per million. We're at 770 deaths per million. I mean, it's and this is completely without a vaccine. We went that, those countries went for an elimination policy,
right?
And we've failed. Can I just, before we go to, we'll have some questions in just a moment from the audience. Just one quick question to Rajani. India is an exciting country. It should be India's century in many ways, but it faces enormous environmental challenges. Do you see a role for community engagement? Is it happening in terms of the environmental impacts that will have such a big effect on children?
Very small scale pilots done by NGOs in really tiny places, not yet at scale, hasn't got either the public imagination or the policymakers' imagination. Right now, all of the environmental efforts are in the realm of legal regulation. It hasn't yet gone down to community, but I have no doubt it will. I only hope it's not too late. But I don't see, we recently introduced within the National Health Mission a climate change cell in every state, and funding for a climate change nodal officer. Nobody knows what that entails. They get a certain sum of money, but it's too less. So we need to build on that and start working it through the health system and taking it down to communities. But I'm afraid we don't have too many local examples in the country to show how it's done.
Right. And just on the, during the COVID, obviously, for the first time for years in Delhi and in Kathmandu and in other subcontinent cities, you could suddenly see the horizon, see blue skies, see the mountains. Did that not awake people's passion about preserving a clean environment, or is it just going back to where it was?
It is back to where it was. The pollution levels have been really bad this last week and weekend. It's a combination of the burning in Punjab and the adjacent states, like the crop burning that season. They haven't stopped that from happening. The traffic is less on the road, but it's all coming back to pre-COVID levels, and people seem to have are either just tired or have given up. Delhi's cases are increasing every single day. We don't have ICU beds. We just added 300 more today, but I don't know how long they can continue. We're flying in doctors from other states, so Delhi is in a particularly bad shape. And the pollution, the cold are just adding to the people who are, especially the elderly who are going to the hospital. So not a good state of affairs today. But Anthony, I'd like to come back to your point and Louis' point about how do you scale up from pilots to large-scale efforts? And I think part of it is in the design of the pilot. So even when the pilot is being designed, you need to think about if the ambition is to, and the vision is to scale it up into large-scale systems, and in many countries it is the government which is the largest scale system, then how do you design the model that it doesn't add on too many new things which cannot be replicated in the large-scale system? How do you work with elements of the large-scale system even within the pilot? So the PLA example for HDUT was great, because they started with a community level facilitator, and then we had the ASHA and facilitator. So I think the home-based newborn care model of Gadchiroli, which we managed to scale up to the ASHA, but one thing you have to compromise. So they did some 23 days of training every year. We could barely achieve 10 days of training in a year. They were able to give their community health workers gentamicin injection. It was a complete no-no at the national level. But despite that, we did see maybe half the reduction or less than half the reduction of neonatal mortality that the Gadchiroli model. So I have more hope for the PLA model reducing neonatal mortality now than I have the individual community health. Thank you.
Yeah, and I think Audrey and Suchitra can probably tell us informally some of the results of their big scale up of women's groups across Jharkhand, and that's looking promising, I think. Let's go to questions. Daniela, have we had any questions from the audience?
Yes, we've had two great questions from the audience. So I'll start with, this is directed to Charles. How has the decentralization process influenced the PLA approach?
Good question. Decentralization, is it happening in Malawi?
Yeah, it is actually. I look at decentralization as an opportunity because, for example, if you look at it at council level, the chiefs are more involved. They get to meet together with the district commissioner and the district health officer. That's when some of the partners can also join in and take it. That's an opportunity because whoever is coming to support can look into the district implementation plans and then support according to what those districts have planned. So I look at the decentralization as an opportunity. Thank you.
Just on that, I mean, I remember 30 years ago working with people in Nepal from the World Bank, and decentralization was very mixed picture. On the one hand, there were people saying you've got to decentralize if you're really going to get local action and the like. On the other hand, when they decentralized budgets, financial irregularities went up quite steeply, and then the government clamped down and kept their budgets back. Is this a problem, a kind of balance that the good districts, the kind of states like Kerala in India that manage their finances well and are devolved, but then you get, you know, the other bureaucracies that are not as good at that, and you get criminality and the like. Is that happening, or is it a mixed picture?
I think for Malawi, I think of course the initial problem is that for some districts, things were decentralized to them before they had the systems in place. Because for you to decentralize, you need to reinforce accounting, you need to reinforce this and that. So unfortunately, it's only recently that some of the districts had the directors of finance. Most of them were using chief accountants or something like that. And now that they've reinforced all those positions, even the what we used to know as the DHOs are now directors of health and social services. So they've been empowered. And yes, there's some districts that challenges with liquidations and so on and so forth, but things are improving significantly now. So I hope that with a lot more training of the district health management teams or other district teams, the problems that India faced may be minimized for Malawi. But I agree. I mean, there are a number of teething problems which we've managed to get over now.
But Rajani, do you face this problem with, you know, some states are really excellent in India at, you know, managing their whole budgets and management systems, but then you've got others that are weak, and you know, the federal government sometimes has to intervene. I mean, one argument for community engagement is that that's one of the best forms of audit and accountability that you can put into a system, because people will be mobilized to keep an eye on what's happening.
I mean, yes, audit and accountability and mobilization, but you have to remember legacy effects, power hierarchies. There are a lot of other things at play that, you know, for instance, the state of Bihar or the state of Uttar Pradesh is not equivalent to Kerala or even Orissa and Madhya Pradesh, I would say. So there are a lot of other things at play. But certainly investments in community mobilization and decentralization, these help. I've seen it over the last 15 years with the implementation of the health systems reform. So preparedness is important. I think advocacy and handholding are really important. And so for me, to make this change to decentralization, effective decentralization happen, I think having intermediary organizations, we really have have their skin in the game for a very long time, and that helps. Whether it's intermediation from the national level or intermediation at the state and district level, having an intermediary organization support the whole process or facilitate it, whether it's community mobilization or decentralization, is very, very helpful. And investments in intermediary organizations or boundary organizations is important.
Okay, let's, Daniela, the next question, and we'll come to Luwei as well.
Yes, we have one more question. I just want to encourage anyone else that has any more questions to click on the Q&A at the bottom if you have any more. So this question is, why, in your opinion, given the huge evidence base for impact and equity improvement, has PLA not yet become the routine way of working in public sector community health systems, while methods with much less evidence continue to be advanced?
That's a very good question. Yeah, I'm going to start with Luwei. I mean, you know, many governments, Congress, Senate, Houses of Parliament, politicians have a simplistic view. They like a magic bullet. Everyone loves immunization. Everyone loves a vitamin A capsule. But when it comes to PLA, which is giving people power and their voice and cross-generational effects and beneficial not just to mothers, but also to their daughters and sons, you know, people seem less excited by that. Why do you think that is? And what can we do about it? You're muted.
I feel it's a tricky question, and it's touch upon politics and not just programs, because it's certainly in situation when does a local authority wants to listen to community and not just listen but take their views into consideration. It's often a political choice, and investing in domestic resources when there is a limited physical space for primary health care, investing in services in such a way that people appreciate, it's convenient for the people instead of politicians. For example, if there's $1 million in a district budget, if you build a hospital, it often becomes symbolic. It could perhaps mobilize the vote of certain parliamentarians. But if you use it for community mobilization and listening, it may even bring your seat down. I even have that example in my everyday management. And that sometimes you let people open up, then you open the floodgate. I think we need to strike a balance, to reach program coverage and at the same time ensure quality and social accountability. I think the locals needs to, everybody here, a lot of ladies from India, from Bangladesh, I think they know how to strike the balance, as well as Charles in Malawi.
Yeah, I mean, just on that, I mean, you're interested in China's aid program. I mean, I've been to Malawi and seen, well, they built the parliament there, but they also built a fantastic new university down just south of Blantyre, the Malawi University of Science and Technology, which is unbelievable. I mean, I was so impressed when I went there.
Right.
So they're extremely good on hardware projects, but do you think they, a bit like, you know, American Magic Bullet programs, will stay on hardware and not really get into the kind of software of community development?
I think China is moving on, is making progress. If you look at what they built 40 years ago, perhaps it's railway and the stadium, and more they're building schools and hospitals and the social facilities. And the next step would be a balance between the hardware and the software, and bring the Chinese, not just about throwing something again symbolic, either it is road, it's important, or a facility, but also along the roads, can you also build schools? Can you build toilets? Can you build water point? Can you have zebra crossing around schools? So there are a lot of things China can do better, but we need to engage them for them to do better.
Yeah, no, that's a good point. And I'll come to both Rajani and Charles about this as well. But, you know, building capacity is incredibly important. And, you know, we published a Lancet thing called a commission earlier this year, chaired by Helen Clark from the Prime Minister of New Zealand, or former Prime Minister, called A Future for Our Children, ? With UNICEF, with WHO. And in it, they emphasize the importance that children, it's not just about the Ministry of Health. Children are affected, and their health is affected by the environment, by housing. I mean, 40% of children in the world live in slums, you know, or in informal settlements and the like. Education, all ministries actually contribute towards health, and it's a way of engagement, is a way of kind of getting communities alive to the notion that they can influence the various, and as you say, structures like good schooling, good housing, zebra crossings and the like are very important for that. But come on to Rajani and Charles. Do you think that, in answer to the question, we have been a bit too obsessed by the technical and not enough by the kind of mobilization of voices and communities and engagement in India? And the question is, why has that not happened when the evidence shows that it actually works?
So, I mean, we have seen a little bit of success in India, at least with the PLA, you know, we saw Madhya Pradesh and Jharkhand. But I think if you, I think it's the introduction of the PLA, the impact that it has on women and children's health, without contextualizing it, makes policymakers immediately feel that it's a very process-intensive effort. And I think that's one barrier. And I think the second area that we haven't explored is the utility of PLA in other departments, in nutrition, in housing, in urban slums. I think we've restricted it to health, at least in India. PLA has been a method that's been very, very focused on health. And we haven't yet, or at least not that I know of, moved it into other arenas. It was good to hear Narine talk about domestic violence, but I think we need to engage with a broader stakeholder platform across sectors to make PLA more visible.
Charles, what about him? I think Lu Wei has to go because she's got to go to meetings and stuff. But thank you so much for joining us, Lu Wei. But I'll come on to Charles.
And thank you. And you can count on UNICEF in every country. Please approach your local office. We're there for you.
Thank you. That's
you.
a very good point. Very good point. And actually, once I went to a UNICEF office in Nepal when we were really short of money for a project, and we had
they didn't throw you out, did they?
No, they actually gave us the funds.
Exactly.
It was really fantastic because it bailed us out from a real problem in Nepal. Yes. And it enabled us to run with lots of programs. So it was really nice. And there was a fantastic guy there called Stuart. Forgotten his surname. You will have known him, but anyway.
McNabb, Stuart McNabb.
Who sadly died last year.
I know. In Scotland.
Wonderful.
Yeah. So he's a unique being, and we have many good people in UNICEF, and please approach them and get them to support what you want to do.
Yeah. Okay. Thanks, Lu Wei. Charles. Oh, talking of UNICEF in Malawi, you've got Bijoy Nambia there. You should go and knock on his door. He'll have some money for you.
He's a bureaucrat now, so you can't just knock on his door. He's got to follow the UNICEF processes.
Exactly. I mean, it is about getting a balance between the technical and the voice of the community, isn't it? Because if we're too far on the technical side, people may not use services or receive them, those that need them most. On the other hand, if we just focus on community engagement and the services aren't there, there's going to be, you're going to increase demand and then suddenly they're not being met. That's a balance you have to deal with every day, I imagine.
Yes, I mean, I did mention when I was talking about the National Community Health Strategy and the pillar that deals with community engagement. I did also mention that we have these hospital management committees and there's health center management committees that undertake quarterly community scorecard meetings to provide a platform for that community interface with the health system staff and the community members. And in this approach, you get community members are involved in the assessment, planning, implementation, and evaluation of performance of health service delivery. So there actually is that interface. And through this, of course, the communities would identify lessons learned, the challenges, gaps, and draw action points for both the healthcare system and the end users. So I guess there's that overlap between the two systems. And if you're looking at PLA and with the facilitated learning, I hope if we work together with that interface, it should be possible to improve the health of our community.
Yeah, thank you. Look, we've only got 4 or 5 minutes left, and there's one more question, I believe, Daniela.
Yes, one last question. So how do you balance the local ownership autonomy that PLA engenders and linking with the government healthcare systems to facilitate scale up?
Yeah, that's a good question.
I think that's what I was also trying. I'd seen the question, so in my response, I was trying to address that issue as well. That is that overlap. But for scale up, obviously, I think governments need to work with partners, and it's easier at local council level using their own district implementation plans. That's how I would look at it.
I think a big issue, if I may chip in, is education and women's empowerment. I mean, when I compare, visiting Bangladesh, Nepal 30 years ago, the difference now is huge in that there are many more people who are educated, dynamic, able to, not in such a hierarchical society, even if it remains a bit hierarchical at times. And also women do have a louder voice. And in a sense, people say this is going to be the Chinese or the Indian century, but I hope it's going to be the female century, because that's what we need, many more voices there who can help to mobilize communities. Rajni, are you optimistic about what's gone on with women's empowerment in India, or do you think there's still a very long way to go?
I'm optimistic on some fronts, but I think we still have a very long way to go, particularly the northern and the western parts of the country, where despite education, despite women being educated, articulate, working in outside of home, there continues to be this huge gender hierarchy and patriarchy at play. And that will take a while. I think perhaps we are one of the few countries left where you still have declining sex ratios at birth. We still have that in some states. Yes, we do. And so in that sense, I'm not very positive. But I think continuing with women's empowerment, continuing with collective groups, with talking about health issues and building solidarity among women's groups is going to be critical for at least a decade to come.
Yeah, and just to say, this is not picking on India or any country. I mean, if you look at Britain, only 5% of the boardrooms in the stock market, you know, of the big companies are women. And we only have to look at, you know, Trump's America to look at the way in which women have been marginalized from decision making. And, you know, virtually every platform that he's on is 80%, 90% men. So I think, you know, one can go backwards, and in Britain as well. I mean, our cabinet is largely men. Most of the people around Boris Johnson, certainly up till this week, were all men. I mean, a couple of them have been kicked out, so it may change a bit, but, you know, it's a constant battle, isn't it, to ensure that you get voices in high politics as well as in local village politics. But on that point, I think we're at time, and I have to hand back to Mark, Mina, and to Annie. This has been a fascinating discussion. I think we've picked up a lot about the challenge of going to scale and not always resting on our laurels in pilot projects, but pilots, well evaluated pilots, are very important. And thinking about how you can incorporate is to work very closely with senior policymakers early on and to link into existing systems. I learned that, you know, with the ASHAs in India, with the community health workers in Malawi, and the female community health volunteers in Nepal. And once we linked in with those systems, there was an automatic way in which one could help to scale up, as well as bringing in various people from the community. So I think this has been really great discussion, and particular thanks to Charles and Rajni. I know how busy you are, and thank you very much for joining us. So back to, is it to Mark or to you, Annie?
No, to me. Thank you, Anthony. And thank you so much.
Thank you very much.
Thank you, Charles. Yeah, it's been an absolutely great event. Thank you so much all for participating, joining, being on the panel, and allowing us to discuss this important topic. I think for me, it's highlighted that there's a great body of evidence, but there's still lots of fields to research further: urbanization, digitalization, and this big question around scale. In 2 hours of a webinar, that's a short amount of time to get answers to all these questions. But I'm pleased to announce that we are at Women and Children First setting up a community of practice, and this will be a virtual community of PLA and community engagement practitioners, researchers, students, and stakeholders. And I will share with you all in the chat a link about where you can register for to join this community of practice, and by registering you will receive more information from us about this. But a key component of this community of practice will be a series of regular and exciting webinars which will be starting at the end of February 2021. And these regular webinars will definitely try to go into more depth about what has been discussed already here today, you know, we can discuss the topic of scale of adapting PLA and community engagement for different health issues and transforming it to take it into different settings, such as urban settings, as we have discussed. So we'd like to engage you now quickly before we wrap up in a poll, just to understand which one of the webinars you would like to discuss first. So the poll has come up now, so please do share which one of these streams and topics you would like to discuss, and we will take that on board and start planning these more in-depth webinars. I can already see you are completing these polls, so thank you so much for your participation. And then all that is left for me to really say is a huge thank you again to your attendance, your participation. Wonderful to have all these partners here, and to have, you know, all the stakeholders involved as well. So thank you once again. We look forward to seeing you at the next events, and yeah, let us continue to take this important agenda from community engagement forward. Thank you.